Welcome everyone. My name is Elena Kennedy and I'm the Chief Operating Officer here at the Illinois Association of Medicaid Health Plans, or as we call it, IAMHP. We are so excited to partner with our trusted partner organization 3M today on this important topic. But before I can introduce our panelists and dive into the presentation, let's take a moment to walk through the platform a little bit more for those of you who might not be familiar. As you can note, IAMHP utilizes the GoToWebinar platform for all of our webinars. A GoToWebinar control panel should have popped up on the right-hand side of your computer. This is your window into interacting with today's presentation. Hopefully at this point, all of you can hear me, either through your computer audio or phone audio. Should you be disconnected from either your computer audio or your phone audio, don't fret, you can connect and reconnect. Should you be utilizing your computer audio, you can at any point transfer to your phone and vice versa. Should you want to use your computer audio though, please note you might have to give authorization of the platform to your computer. Additionally, if you or a colleague loses audio connection at any point, please direct yourself to the questions tab. The questions tab is great for any technical questions about the platform you might have, but is also a great way for you to ask about what's going on at IAMHP. I'll be answering a few of those questions as we move along, or questions you might have about today's presentation. We will be having a Q&A portion at the end of today's presentation, so please submit questions along the way so that they can be asked during the Q&A portion. We'll do our best to answer questions. If we don't get to them, though, we apologize and we'll try to follow up with you afterwards. Last but certainly not least, we have our chat tab. This is a great tool for you to create community with other attendees today, as well as myself. Please note, however, that due to the version of GoToWebinar you have, as well as your internal firewall protections at your organization, you might not be able to access the chat tab. We apologize for the inconvenience and appreciate your understanding with that. With the logistics out of the way, let's dive into why we're all here today. So as noted, my name is Elena Kennedy and I'm the Chief Operating Officer here at IAMHP. And as noted earlier, we are so excited to partner with our trusted partner organization 3M for this important discussion on the implications of economics and social risk that ultimately lead to health inequalities. During today's presentation, our panelists will explore the value of integrating clinical and social risks when considering the development of value-based care strategies. But I'll let them explain that a little bit further. With that, let me introduce our panelists today. We have Melissa Clark, Dr. Melissa Clark, and she is the Senior Medical Director of Healthcare Transformation and Health Equity here at 3M Health Information Systems. And we have Jeff. Jeff, correct me if I'm wrong, is it turnip seed?
Yeah, that's correct, turnip seed, just like it sounds.
Perfect. And he is the Clinical Engagement and Strategy Executive at 3M Health Information System. It is always such a pleasure working with our trusted partner, 3M. I have thoroughly enjoyed working with them in a variety of different ways. We have a variety of different podcast recordings with them and have partnered with them on a variety of other webinars. If you're interested in learning more about those after today's presentation, please check those out on our website. But today we are here to talk about this important topic. So I'm going to turn it over to Dr. Clark to get us started. Dr. Clark?
Well, thank you so much, Elena, and we enjoy working with you as well. And greetings to the IAMHP audience today. Thanks for joining. So I just want to briefly review what we're going to be talking about. I'm going to start off with an overview of social determinants of health, just to level set. And it's also going to include the costs that are related to unaddressed health inequities. And then Jeff's going to take us through a way to gain insights about your population through having an integrated view of clinical risk and social risk. And then I'll come back to just summarize at the end with some potential use cases for how you can get insights, how these insights into your population will be able to help you implement programs and get a handle on the utilization and outcomes through the lens of what we call potentially preventable events. Next slide. So just to start off, many people associate creating health equity, the equal opportunity for everyone to make choices that result in a long and healthy life. Many people associate health equity in our health system just as the right thing to do, which it is. But I think it's also important to highlight that there is an economic discussion that can be had and that needs to be highlighted when we consider our system and the process changes that need to happen to take us in the direction of health equity. Next slide. So let's just level set around social determinants of health. I know everyone who's listening to me already knows what social determinants of health are, but I love this slide because it illustrates three really key points. Number one is that an individual's burden of illness and injury, so the components, those components of the boulder on the hill, rest on a variety of community living and working conditions that you see embedded in the hill, which, if they're working against you, make achieving individual health a daily uphill battle. And then the behavior and lifestyle pieces, which are also part of that boulder, heavily depend on social factors as well. We often think of choice as something that's just individual free will and just totally up to us. But oftentimes, choice regarding health is also framed by the neighborhoods and our life context based upon where we live, just as the choice to have healthy foods might be dependent on access to fresh produce, which is often hard to find in marginalized neighborhoods. And then finally, on the right-hand side, those social needs in blue are what result when community level social determinants of health, the ones embedded in the hill, go unmet and impact the individual negatively. Next slide. A lot of times we think about social determinants of health as being mainly affecting people living in close quarters and in urban environments. However, when we look at rural areas, we see that adverse social determinants really play a huge role in the disproportionate burden of heart disease, lung disease, cancer, and stroke that exist in rural communities. And that's due to higher rates of smoking, obesity, and high blood pressure. Compared to metro populations, rural residents have lower post-secondary educational rates, and lower incomes, and rural young people have disproportionate incidence of tobacco use. And then on a community level in rural neighborhoods, there are gaps in care due to distance from providers, provider shortages, and broadband access in order to do telehealth. And believe it or not, in rural environments, there's also nutrition insecurity. Next slide. For too long in healthcare, we've really not accounted systematically for social determinants of health and how we deliver healthcare. So why should health plans now be focusing on social factors and how they impact health? Well, number one, social determinants of health are clearly linked to health outcomes in the literature. So those factors embedded in the hill account for at least 50% of what determines health outcomes at the level of the zip code, not at the level of the doctor's office. And health behavior that we talked about before, so choices about healthy food and exercise and tobacco use, etc., account for another 20%. But just like the food example, these are often tied to geographics as well. Even the choice to use alcohol and illicit substances sometimes may be self-treatment for communities where mental health providers are scarce. And we as providers and payers are now accountable for the outcomes of our patients, so we have to have a handle on what the drivers of those outcomes are and a clear line of sight for how to influence them. We know people with adverse social events tend to have higher chronic disease burdens. Health maintenance may assume a lower priority due to more pressing challenges of everyday living. And then even patients who prioritize their health may not have the adequate resources to maximize their health. So our interventions have to take these factors into account. The other interesting trend is that health disparity quality measures are here. NCQA, as you probably know, have developed HEDIS measures that now include race and ethnicity. And so it's important to now start to report on those and combine them with the 5 HEDIS measures for which health disparities outcomes are being collected. And those 5 are going to expand to 15 in the coming years. And then finally, the cost of care. As you'll see later in the presentation, adverse social determinants of health are clear drivers of what we call potentially preventable events. And Jeff's going to go into a lot more depth in helping to define what those are. But essentially, those are readmissions, admissions, ED visits, and complications where there might be an opportunity to avoid those happening. They're excess above what would be expected for that population. And so that's yet another reason to be able to have clear line of sight in order to help your members get timely care at the appropriate site of service to maximize the triple aim. Next slide. So these potentially preventable events and excess utilization are closely tied to national and state studies that show the cost to the economy of unaddressed racial and ethnic inequities in healthcare. So as you see on the slide, addressing these inequities that are closely tied to social factors could save in 2011 dollars, so even more now, the equivalent of $1.2 trillion of direct costs, as well as indirect medical costs, indirect costs like productivity and premature death specifically. And a similar study in Minnesota, so on the state level, showed that their same parameters could result in savings of $3 billion related to productivity loss because of preventable death and disability due to preventable disease related to health inequities as seen in communities of color. Next slide. And since those studies were done, we've seen how utilization and cost are being managed successfully through interventions that address social needs while simultaneously improving a patient's quality of life. So these examples are drawn from a variety of markets involving both Medicaid and Medicare beneficiaries, and consistently are showing decrease in inappropriate ED visits, ambulance usage, and decrease in spending due to care coordination that focuses on 3 of the major social risks: housing, transportation, and food insecurity. Next slide. So in order to really get a handle on social risk, you have to be able to capture it in order to tailor the programs and interventions that you're going to make. But there are challenges to capturing social risk. The most obvious place to start is by asking the member during point of care encounters. So this clinical setting, though, presents some issues. It requires an individual, obviously, in an attributed population to be sitting in front of you or on a televisit to be able to capture the data. But we know that there are lots of missed appointments and therefore missed opportunities to do that. The other thing is many providers have not reliably integrated social data capture into their workflow. So even if somebody is in front of them, that's yet another missed opportunity. And then finally, in getting that information into the record and into the claims data, Z codes, which is what are used to capture this information, are not specific enough yet to capture actionable social diagnoses and barriers to improve clinical outcomes. So for example, on the slide, we see Z59.6 that just says low income. But the codes underneath in red, which are proposed codes, not yet adopted, give much more insight into how the low income is affecting the desired clinical outcome. So because of these challenges, geographic data sets are now where a lot of data analytics are going as a way to understand social risk, using census tract data or zip code data as a proxy for individual address. And that's because we know much of the variation in life expectancy among US counties and neighborhoods can be explained by the upstream social factors we've already been talking about. Examples are linkage of neighborhood deprivation, for example, to maternal mortality. And this geographic data increasingly is being used to predict cost of care and determine risk-adjusted reimbursement models. It's being done by MCOs in Massachusetts, for example. But the obvious downside is it's not ideal when you're doing care management to understand an individual's particular challenges. So I'm going to stop here and turn it over to Jeff to talk about 3M Social Determinants of Health Analytics tool and how we're able to take this social risk data both on the individual level and the geographic level and combine it with our clinical risk grouper methodology.
Great. Thank you very much, Dr. Clark, for that very thorough introduction on the business use case. And I'm excited to share with you how 3M is approaching solving this problem for the market as you sit as a health plan, a provider, or really just looking at it from a community-based perspective. So many of you may know 3M as all of the clinical groupers and methodologies that are industry leading that help us assess clinical risk adjustment, like you see on the left. That data can be used for value-based payment. As Dr. Clark mentioned, that we have a suite of groupers that look at potentially preventable events. Here it's called avoidable health services. And just to recap, that includes potentially preventable admissions, potentially preventable ED visits, potentially preventable readmissions, potentially preventable complications, and also potentially preventable ancillary services. So you can think of these events as the low-hanging fruit in the healthcare system where we're most likely able to address through a more efficient and effective system that generates better outcomes. You can track these things, utilization and cost of dollars over time. But that's all tied to the clinical data and claims feed that we get from health plans on a monthly basis. And then we're also able to identify chronic medical conditions. And that information is integrated into workflows. It's used from network management perspectives. That is what 3M has been known for. That's what we do. What really makes this exciting is their partnership with Socially Determined, where we are now in one platform integrating the Socially Determined's expertise in terms of the domains that you see there, where they have curated data that allows us to surface that at a zip code level as well as an individual member level, where you look at those domains: financial strain, food insecurity, housing instability, transportation barriers, health literacy, and COVID-19 susceptibility. And we've put this data together in one integrated platform that scales. So if you have 1 million covered lives in your data asset, we're able to get you information at the zip code level and member level for almost all those members as long as there's a match in the data set. And that can be done with just basic eligibility information and claims feeds that we get from all the payer clients we work with. So it's really exciting that you're talking about a platform that really allows you to analyze this data from a clinical perspective at scale. And so just to summarize, what we're really talking about is social plus clinical insights that leverage 3M's clinical risk groups, which are what we use to classify individual risk, the whole person, not just a single disease. The industry leading socially determined social risk factors that we discussed there, and I'll give you some examples later. And also leveraging 3M's potentially preventable event suite that's been widely adopted by state agencies in different capacity, but is fully integrated into this socio-clinical risk analytics solution. So one of my favorite quotes here that sticks with me, and this is not from a 3M perspective, this is just from a personal perspective, is that if a patient's social needs are not met, their medical needs can't be met. We really need to understand both of those pieces of information and be able to do that in a comprehensive way. And what we're talking about from a member management perspective as a benefit is that this allows health plans to leverage the clinical risk groups and social risk factors to be very targeted from a member management outreach perspective. If you take a step up and want to look at things from a pop health perspective, all of this data can be aggregated, and then you can layer that in with potentially preventable events as well as the cost of care that's being delivered. And of course, that leads itself to, the types of questions they're going to get. As Dr. Clark mentioned earlier in the presentation, there's no doubt there's a lot of economic benefit that is in front of us to improve the healthcare system. And we want to be able to account for that, and we'll need ways in which you have analytics infrastructure to be able to track your investment, the resources you're putting in as you scale those resources up in the community or partner with other organizations. Share that information with them so that they can make informed decisions and then track that improvement over time. So performance monitoring is another key benefit to what we're talking about. So for those of you who are not familiar with clinical risk groups and potentially preventable events, this slide helps sum it up in a nice way. And what you're looking at on this screen is the size of the bubbles. This is taken from a commercial insured demo data set. But those are the number of people in each bubble. And the bubble itself, at the top right-hand corner, complex chronic and multiple complex chronic as an example, are an aggregated view of 3M's clinical risk groups. So you can get all the way down to a very granular level and look at someone's individual CRG, or even break that apart and look at the specific EDCs or the diseases that make up that profile. And as a reminder, it's a clinical grouper, so you can unpack this and drill down into this data. But it shows you the stratification. The CRGs alone can show you the stratification of the costs, the clinical assignment itself, but also the associated costs of the potentially preventable events juxtaposed to that. And you can quantify that as you see there, that 14% of this data set represented 44% of the total costs, and the potentially preventable events specifically were $177 million. And so it's the CRGs and PPEs alone are powerful tools for you to be able to track all the good work that the health plans are doing to try to create more efficient system working with its providers. But this slide is showing you how you can aggregate the PPEs together. And the PPE cost that you see here on the vertical axis are aggregated across potentially preventable admissions, potentially preventable ED visits, potentially preventable readmissions, and potentially preventable ancillary services. So we can aggregate those events together. We can also break them apart in case you're looking at refining how you might use this type of information. But let's switch gears and take a look at the combination of clinical risk, which is on the right here under the clinical risk score, and the type of ways you can think about using social risk scores in combination with that. So imagine whoever you'd like in the middle there, but it's a 67-year-old female, for conversation's sake, that's been a member at your health plan for greater than 3.5 years. We can tell from the social data that we're gathering what their annual income is, a range, that they live alone, are a homeowner, they have $200,000 in value, they own a car, right? So this social profile is created, and we can tell maybe how far away they live from a pharmacy, or that they might need to, they're far away from healthy food options. So we can assess the social risk through this data we're getting from Socially Determined. And on top of that, from an analytics perspective, we are getting actual risk scores, which range from 1 through 5, and each of those risk scores can be attributed to an individual, okay? And so what that allows you to do is take the clinical risk. So we know that this person's CRG is multiple complex chronic, they have congestive heart failure, diabetes, and COPD, severity level 2. That's the stuff that comes from 3M. The socially determined data allows us to layer on that whether or not somebody has an elevated risk in any of those domains. So if somebody has a social risk score of 4 or 5, you can very easy in the analytics identify those members and think about stratifying your population in ways or refining your programs that you may have in place to address individual specific needs, as well as roll that information up to communities that might have higher elevated risk as well, social risk and clinical risk combined. So what we are able to take in order to make this happen is a standard claims feed along with demographic information that you would typically send, like a pop health vendor. So we need eligibility, facility provider data, and all your claims data. We typically get that in on a monthly basis. Then we we integrate the social risk data. So what comes along with this are clinical risk group assignments, the PPEs, preventables that we discussed, so in the examples earlier. And you can choose how you want to consume this. It really can depend on your use case. You can consume this through a self-serve business intelligence tool, which is our social determinants of health analytics module. That's one of the modules within the larger informed analytics suite. And then as our clients are already finding that this data is good to help inform decision making in a BI tool, but it's also important to have that work interoperably with your community benefit organizations or care management workflows that you might want to integrate this into. So let me just switch gears and then talk to you a little bit about some of the insights that we've already gained leveraging 3M's SDOH analytics. The first point that I think is super important is that the data has been validated, meaning that we have taken data in for members using an eligibility file from a health plan. It's been looked at by our clients, in this case, the beta client, and they've gone through and found the data that they had questions on, validated that the data that they're getting from socially determined was actually meaningful and information that they couldn't or didn't gather because either the questions that were asked by their care management team or their outreach team didn't quite get to the information from the individual. They didn't tell them that, or they didn't feel comfortable telling them that, but the data from socially determined is helping them follow up and better inform decisions across the board, not just from the patients that they're able to reach out to directly. Additional social risk identified for members currently under care management practice. So you have current care management programs, and the data is going to help you refine patients that are already in your care management program to maybe further stratify that risk, work smarter with the programs that you have today in place. It'll also help you think about scaling those programs larger within the community too. For instance, generally speaking, about 30% of a population, if it's commercial, Medicare, Medicaid, it can vary, are non-users. That percentage can range. But if they're non-users, when I say that from a clinical perspective, you don't have any claims for them. In order to get the claims, you got to reach out, bring them into the doctor, and even then there's a lag for you to really understand their clinical risk. The social data you can layer in and illuminate that 30% of the data that you don't have clinical information for, maybe new members that you pick up in your health plan because your business is growing. This data can be layered in and integrated into your clinical analytics workflow seamlessly, meaning you can pair that up and integrate it and leverage the SDOH data to help fill that gap. It also helps you work further upstream for members you might have that clinical data at hand early on. And then you can integrate this data right into your workflows. So whatever criteria you might use, you can add in social determinant criteria for that, along with clinical criteria. And really building on the foundations of 3M's clinical risk groups, all of these things I think are key findings that we're finding success on. Next, some lessons learned that it's clear that even after what we suspected to be true and what we're hearing is that there is survey bias. So as much as we want to code for everything, right? And there's a Z code for all the situations that we need. You're not always going to get that information. Even when you ask, there could be some bias in the response that you get from the patient. So we want to make sure that the member-provider relationship is strong, right? And that they're coming in and that relationship is there. But even when they are in, you want to, the data that you collect there could be some bias in that between the member and provider, et cetera. And there's some subjectivity of need there as well. But another important point here is that getting that information in a single point of time is what solves for one problem. You want to be able to understand if there's growing risk in a community, or if someone's social needs are being met, how is that changing over time? So you want to be able to uncover the growing clinical and social risk, and the solution that we're talking about helps solve for that. And sensitivity to patient environment communications. You know, sometimes it's just not, you're not able to get that information due to the sensitivity of how that question can be asked and in what environment. So there's more that we're learning as we go along, but these are just a few lessons learned here as we start to delve into this space more. So some of you might be asking, what does this kind of look like? This is a very helpful view, because what you see on the horizontal axis here is non-users, healthy, minor chronic, multiple chronic, et cetera. And that's an aggregated view of 3M's clinical risk groups. We call them patient segments or population health segments. And then what you see for each bar are the specific domains from the socially determined data, which goes across each of the domains that you see there. Now, what you can see here is that, generally speaking, if you draw a trend line, that social risk across all the categories increases a little bit the more their clinical risk increases. So from non-users over on the left, those are patients that don't have any claims at all, no pharmacy data, no claims at all. You can still see where their social risk variances are within the population. But as you move across the spectrum of multiple complex chronic, you can see how those social risk categories change. And of course, this can be pivoted by zip code or by clinical status, like just looking at your diabetics or patients with diabetes and mental health conditions. You can slice this a bunch of different ways, but in general, we see a general increase in each domain. So you're able to layer on the clinical classification with the social risk in this view, and then break this down from a zip code level all the way to a member level where needed. Additionally, Dr. Clark mentioned that we get into a little bit more detail on how you can tie this to potentially preventable events. So, and also just social risk progression in general. We see on the chart to the left that the percent of members with 2 or more individual risk factors show a modest correlation with elevated social risk, show a modest correlation with disease progressions. In other words, if you have more than one chronic condition, you're showing a higher elevated social risk, and you can see how that kind of step down applies to members that only have one moderate or complex chronic condition there in the second bar, and then the third bar is where you only have one single chronic condition. So the analytics allow you to break that out and look at the variation that exists in your data. Additionally, just looking at potentially preventable ED visits, that's what PPVs stand for, on a clinical risk-adjusted basis, when we account for the clinical risk, patients go to the emergency department at a higher rate when there are members who have higher elevated social risk. So that means that their social risk was a 4 or a 5 on the scale that we looked at on the previous slide. Risk adjusted, so you're taking account their clinical risk, they go to the ED more. So if you're looking to make even the internal business use case to leadership at your health plans, that this is something that you need to invest in, think about how you allocate resources. These PPEs can help you track your improvement, but also even up front, make the case that you need resources to begin to stem the tide and improve the efficiency in the networks. And so just to summarize, social risk is correlated with increased clinical risk, potentially preventable events and utilization, but not necessarily total cost of care. It's not always the case that a patient costs more because of the way benefits are designed or et cetera, but we are seeing that it ties to utilization nicely from an overall social risk perspective. Health literacy, this is a little This makes sense, but it's concerning that health literacy specifically highlighted not just for an increase in prevalence, but an increase in rate with increased clinical risk. So as their clinical risk got, someone got more risky from a clinical perspective, their health literacy, the rate of risk there increased. So something that popped out to us in our work on this, we thought you might find that interesting. And then not all social factors behave similarly. So as you can imagine, you know, if you're thinking about solutions for something like this at a zip code level, we at 3M were concerned about that because we wanted to make sure we brought the solution to market that addressed the zip code level, but also enabled our clients to be able to unpack this data at an individual member level. So you can make member specific interventions that matter to that individual at scale. And of course, this builds on a clinical foundation of 3M's clinical risk groups and all of its clinical groupers. And with that, I'll turn it back over to you, Dr. Clark, to talk about some of the potential use cases for 3M SDOH analytics.
Great, thanks, Jeff. You could go to the next slide. So use cases for how do you take all the wonderful information that Jeff just outlined and put it to use in real ways in the everyday business of the health plan. So this integrated view, first of all, allows you to strengthen population health and value-based care in three important ways. The first is with member care management. We heard a lot about that already from Jeff, answering questions like, which one of my members accounts for the majority of my spend in preventable events? And having a strong understanding of that by plotting clinical risk against preventable events lets you be able to understand the complex chronics in this chart that Jeff went over prior. So the complex chronics and the multiple complex chronics, and understand and then drill down into those populations to understand the individual clinical risk, as well as overlaying the social risk on there so that you can then do targeted and effective member outreach, not just based on the disease state, but actual an individual's total burden of illness and total social risk. He also highlighted already how you don't have to wait to understand information about your new members. Out the gate, you can have an understanding of social risk and start to outreach to them even before you start to get additional claims information. And then it, of course, because of the way the data can be made available, it can promote effective communication and care coordination with community-based organizations around the members in your plan who need it the most. Next slide. So that's member care management. When we're talking about performance monitoring of programs, this integrated view of clinical and social risk can allow you to monitor the interventions that you make in your population. So this is a great example of looking at the issue of higher maternal mortality among Black women. We see that it's 3 times higher than that of whites and 6 times higher the rate of childbirth-related injuries happen with Black women versus white women. And this factor, one of the factors that weighs heavily in this is health literacy and advocacy. And what's been found to be effective is integrating and reimbursing doulas or perinatal health coaches during a women's pregnancy. So if you wanted to structure an intervention around this, making doulas available to women who are at higher risk, you could then use this tool that has a view of integrated clinical and social risk to choose a cohort. So for example, women who might have comorbidities, who might in prior pregnancies have had comorbidities, tobacco use, proximity to or prior use of antenatal care, and also individuals with low health literacy. And choose this cohort to focus on, with your benchmark being what is the rate of potentially preventable ED visits and potentially preventable admissions and complications that this cohort has before and after your intervention. And you're able to track this because of the ability to see the integrated clinical and social risk, but also see the outputs of the potentially preventable events. Next slide. And then finally, you can map where your members are geographically or view them by the provider or the network that they're in. So you can start to understand where at-risk neighborhoods are by specific type of social risk. So for example, this is a view of areas where health literacy is lower within the state of Ohio. And you can work with CBOs, community-based organizations, on specific programs in those neighborhoods and provide additional resources in those areas to meet that need. The other thing you could do is what I call building high efficiency networks. You can see which providers in networks have higher proportions of members with increased social risk and increased clinical risk in their panels, and ensure that those providers have access to the resources that they need to achieve improved health outcomes for their populations. You can also look at value-based program design to ensure that those providers are proportionately rewarded based upon the additional work that they may have to do to achieve similar benchmark outcomes as far as potentially preventable events compared to more resourced populations. Because the potentially preventable events are correlated with higher adverse social risk, those providers that reach those higher benchmarks for members that have increased socio-clinical risk are likely achieving greater savings, and so appropriately constructing value-based programs to help build these higher quality, higher functioning value-based networks can ensure that all members have a similar quality of care and also the opportunities to achieve better health outcomes. Next slide. So I'll stop there. I think we have a good amount of time for Q&A, but I wanted to make sure that you had our contact information if you're interested in reaching out to learn more about 3M social determinants of health analytics. So thanks, and we can open up to Q&A now.
First of all, before we open up into Q&A, I just want to pause and say so many thanks to Dr. Clark and Jeff for taking time out of their day to educate us. I definitely have a much more larger understanding of the impact of social and clinical risk on potential preventable healthcare utilization. And my God, at one point I was so feverishly writing, I think my hands started hurting. Bearing that in mind, don't fret if you were just like me and we're trying to be as much of a sponge as you could be. We will be sending out a recording of today's presentation to all of our registrants so that you can re-listen to the very thoughtful presentation brought to us by the 3M team. With that, please also note that if you do not have access to a pen or forget to screenshot their contact information, we will be sending around a recording so that you can always reach out to Dr. Clark or Jeff with more thoughtful questions. But for now, you actually do have 15 minutes for Q&A, so should you have questions, please submit those via the questions tab on the right-hand side of your GoToWebinar control panel. If you don't mind, though, I'm going to take a first stab at the questions before we dive into our attendees. You know, ultimately, you talked about so many different things, you know, how to coordinate and align value-based care programs with equity initiatives, you know, identify and focus on, you know, clinically vulnerable populations, and then how to combine this to really assess whole person care. And so there was a lot of different topics, but ultimately, what is one thing you would want all of our listeners to walk away with, or if would you want them to start thinking about after today's presentation?
Yeah, that's a great question, and I'm sure Jeff and I probably have different ones. So I'll take a stab at that first, and then turn it over to Jeff. Um, I think it's really important to understand that you can't think about social risk and clinical risk in isolation. I know that we're sort of, as a healthcare community, pretty young in terms of trying to integrate the two. And we have, for the most part, been looking, as we've tried to grapple with social risk, been looking at it essentially in isolation, and maybe having a program around food insecurity, or having a program around having Lyfts or Ubers help to transport patients here and there. But the efforts are not necessarily well coordinated or well benchmarked, especially when we might be doing them with community-based partners. I think the key takeaway here is that to have the most powerful insight, and therefore the most powerful effect, that it's really important to combine social and clinical risk into one view and understand how social risk impacts clinical risk, and then how various comorbidities impact each other. So we start off at 3M with the understanding of how the various comorbidities impact each other to to um, to create greater clinical risk. But now, because of our relationship with socially determined, we're now able to add into that mix and fold into the picture how social risk actually advances that total clinical picture, and then sets you up for greater potentially preventable events, such as we talked about. So it's really that combined understanding, I think, where this platform sort of takes things to the next level.
Yeah, and I would add it's exciting because for so long we've heard the intent behind the healthcare system. You hear the buzzwords patient centered or consumer focused, right? And we've all heard these buzzwords. This type of information, this type of platform, in the direction we're heading, allows us to literally understand someone's individual relationship with their community better, and vice versa, the community relationship with that individual and the risks associated with that. And that changes the dialogue. It changes how you think about investing. It changes the way you think about aligning your resources in the community. Not that you haven't been doing that before, but it's going to give information for us to all look at and understand. And I'm excited about that. So I would hope that today you take away we energize that a little bit more, if that's the only thing you take away from our presentation today.
Wow, and I love what you both said, and I want to build on what Dr. Clark had mentioned. There's health-related stigma also, and it's a complex phenomenon. Having worked within the HIV sector, we talked a lot about the concept of intersectionality, and we talked about there are no spaces in which a person just lives in a vacuum. The
Right.
person needs care. Housing is health care. How do we also ensure that people are having access to food and clean air and all of the different things that come with that? And so I'm really excited to hear organizations such as yours and other partners within the Illinois healthcare ecosystem really taking a lens to that even further. And I know that it's a priority of the Medicaid managed care plans as well. And they have done so much work on community engagement and focusing on this space. And so I think your conversation is very topical and really appreciate it. Building on some of that and lending into it, here in Illinois, we're very focused on that. But are there states that are currently using the social determinants of health practice data for their healthcare transformation efforts?
Jeff?
Yeah, sure. Well, there's a couple things. One, I can tell you that socially determined themselves have been in their expertise is the social data. And so the answer is yes, they are working with states, and this data is being used in a number of ways. But also can tell you that, like for instance, in Florida, We have the beta client that you saw up there. I'm happy to send a case study on this afterwards too, if there's any interest. But our beta client that we worked with is taking the social data and the 3M clinical risk data together and then feeding that into their care management workflows as one example. And I kind of see that playing out with other health plans too. So we're in active conversations with health plans all over the country right now with what you just saw today. And I think that the social determined data that's being sent to us by socially determined is a mature set of information, if you will, that is being leveraged by states and health plans actively. We're now talking about the integration of it in one platform. And I think that's the distinguishing factor I want to mention. But early results are very positive, and anytime that we can work with our clients to refine their thinking, help them work smarter with the programs they're putting in place to improve community-based outcomes, it's a win-win for everybody.
While you're waiting for questions, I wanted to go back to what you said about intersectionality, and wanted to mention that one of the things that experiences I bring to this work is having worked with a care coordination program for Medicaid beneficiaries who predominantly had substance use disorder and opioid use disorder, and how the intersectionality of the fact that 50% of the individuals were housing insecure, which doesn't necessarily mean they were sleeping on the street, but they were couch surfing and going to different relatives' houses. A high proportion had coexisting mental illness, and 90% were tobacco users. And so when we think about the opioid epidemic and interventions that need to be made with that population, having a clear view again of how those factors intersect between opioid use disorder, comorbid conditions, and lifestyle factors and social determinants of health, to be able to put together interventions that are holistic and make sense and are not piecemeal, as I mentioned before, where you might be addressing one thing that might be minor for that one person when there are other issues that are more urgent and more immediate for them.
I couldn't agree more. I definitely agree that medical institutions really need to turn their lens towards that intersectional mindset and that frame of work, including factors and thinking about the factors of race, gender, sexuality, even class, and those different things. And when I was a fellow at the National Council on Behavioral Health, we toured around different healthcare systems across the country. And one thing I learned for certain was, you've seen one Medicaid program, you've seen one Medicaid program. I mean, they're all so unique and different to meet the needs of the population. And yet, while there were variations and structural differences of the program, we're still human, and the need for housing and the need for those things were still there, and there was the humanity element of it. And so it's interesting, though, when you are talking about those elements and the humanity, leveraging data and how that you can still utilize different tools, technical tools such as this, to help bring that more humanity lens to the conversation as well.
Yeah, you touched on something I wanna highlight, is that the solution we're talking about here is, sometimes you'll hear something created for Medicaid or for Medicare, or it's something that targets a commercial. These are both the social data we're talking about and the clinical groupers are line of business agnostic. They're not something that's designed just for Medicaid, although you can look at it that way. I want to be clear about that. These are people groupers, they're community-based solutions, and I think that's a really important thing to take away. It's not just about Medicaid or Medicare, it's about the person and it's about the community that they live in. Does that make sense?
Great point, especially given we have a variety of different attendees with different viewpoints and lenses and backgrounds and experiences, both from the provider experience as well as from maybe the health plan perspective, as well as community advocates listening today. And I think that that's an important emphasis to have as we continue this discussion and we think back on today's presentation as well. And I also appreciated you adding that additional color for utilizing this data for healthcare transformation. Here in Illinois, we are trying to reorientate the healthcare delivery system around caring for people's physical health, behavioral health, social needs in a coordinated fashion across our local communities here in Illinois. And so as we're having conversations about healthcare transformation collaboratives and healthcare transformation overall, I think leveraging data and reminding us that we can utilize tools like this or other resources is also an important thing. So I really appreciate that as well. With that also, though, I want to ask your clinical expertise as well as just your expertise working within the data space. We've learned so much because of COVID. I mean, we're just inundated with different ways to address healthcare, and there's an opportunity really for us to reassess how business was done as usual. And I want to just get your perspective. What do you see on the horizon for healthcare moving into 2022? I know it's crazy to say so early on now, but what do you see for the vision of healthcare delivery, and how can tools like this continue to bring us into that next transformational space?
Well, I think, as you mentioned, COVID-19 and the pandemic has highlighted what we in healthcare have known all along, are the health inequities. We've seen communities of color, of course, having differential increased exposure to COVID-19, so therefore disproportionate number of cases, and then disproportionate numbers of deaths linked to underlying chronic conditions, linked to health care disparities in terms of access to testing, vaccines, and PPE, and historic mistrust from communities of color. I think as we move into 2022 and beyond, I think there's an imperative to continue to work to close those gaps. And I mentioned that NCQA has sort of stepped up their disparity measures, incorporating race and ethnicity to try to understand how those are impacting the care that is provided. This tool, our 3M Social Determinants of Health Analytics tool, does digest race and ethnicity as data points. And so as you start to take that and overlay that onto your clinical risk groups, you can start to see where the areas of need are, again, so that this tool then becomes a way to rise to the challenge of addressing health disparities and health inequities within your population. And the point that I made towards the very end, as we move more into a value-based purchasing environment, only somewhere less than 30% of revenues of providers come from value-based programs. So there's a huge amount of ground to make up. And as we construct those value-based programs and build those high-performing networks where we can be assured that disadvantaged communities are receiving the same level of care and the same opportunities for improved care as more resource communities, it's essential to be able to use this kind of data to be able to adequately construct incentive programs for providers so that they don't cherry pick patients, so that they don't, so they're inclusive of all the patients who they would want to care for and not really worry about the fact that they might lose out financially in the end by beefing up their patient-centered medical home model, for example, and getting PCMH certified to be able to provide more services and have a holistic view and coordinate with community-based organizations and have a social worker embedded in their practice, etc. All the changes that need to happen, that the practices are adequately resourced to take care of all patients who may have a variety of social challenges.
I second what you say, Dr. Clark. Very well said.
Well, as always, I love partnering with the 3M team. Thank you so much, Dr. Clark and Jeff, for joining us today. And thank you to all of our attendees and listeners now and at a later date for taking an important hour out of your day to engage in this conversation. And we hope you enjoyed it and continue to ruminate on it after you listen to it. With that, we will be ending today's presentation, but should you want to continue the conversation, please always reach out to the IAMHP team or the 3M team. Additionally, please like, share, and follow us on Facebook, LinkedIn, and Twitter, as we have a lot of other webinars and updates on our social media as well as website. With that, have a great day, and I look forward to talking with you all again soon. Goodbye.
Thank you, Elena, and thank you to
Thank
the
you.
audience. Bye-bye.